Good morning, ladies and gentlemen. We warmly welcome all of you to the Bibile Memorial Oration of 46th Annual Academic Sessions of Kandy Society of Medicine. Kandy Society of Medicine, or KSM, celebrates its Diamond Jubilee this year.
Thank you, ladies and gentlemen. Please take your seats. The Kandy Society of Medicine has its inception back in 1963 with 3 young enthusiastic consultants working at Kandy General Hospital along with the help of the then medical superintendent. These meetings then shifted to the Physiology Theatre at the University of Peradeniya back in 1964. With those meetings, the term came the Tuesday Talks. And Kandy Society of Medicine has progressed a long way, and yet here we are today at Bibile Oration 2024. Ladies and gentlemen, please rise for the national anthem.
Sri Lanka Mata, Upper Sri Lanka, Namo, 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 Namo Mata. Sundara Sitarini, Surani Ati Sobhamana Lanka. Ranya Danaya Mekamal Valaturu Piri Jaya Bhumiya Ranya. Apamata Sapasiri Sata Sadhana, Jivanaye Maga. Dilidanu Mena Apabhakti Puja, Namo Namo Mata. Upper Sri Lanka, Namo 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 Mata. Upave Apavidya, Upavaya Apasatya, Upave Apashanti, Apahada Tulabhakti, Upa Aloke, Apage Anuprane, Upa Apajivanane, Apamuktiya Upave, Navajivana Devini, Nikina Apakubukaran Mata. Jnana Veeda Vadavani Naragena Yanu Mena Jaya Bhumikara. Ekkamavakade Daru Kalavedina, Yamu Yamu Vinopama. Prema Vada Samaveda Duralaya, Namo Namo Mata. Upper Sri Lanka, Namo 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 Mata.
Ladies and gentlemen, please remain standing. To begin today's proceedings with the lighting of the oil lamp, let me cordially invite the orator, Dr.Damitha Gunawardane, the president of KSM, Professor Saman Nanayakara, the chairman of scientific sessions, Professor Tushara Kudagammana, and the joint secretaries, Dr. S. Krishna Pradeep and Dr. Nishan Dharmasena.
And a family member representing the Bibile family, Dean Faculty of Medicine, University of Peradeniya, Professor Vasanthi Pinto, Dean Faculty of Dental Sciences, Professor A.M. Artigala, Provincial Director of Health Services for Central Province, Dr. Nihal Veerasurya, Deputy Regional Director of Health Services, Deputy Director of National Hospital Kandy, Deputy Director of Teaching Hospital Peradeniya, and Treasurer of KSM Dr. Tusitha Padeniya.
Thank you, ladies and gentlemen. Please take your seats. Next, it gives me a great pleasure to invite the following distinguished dignitaries to the head table. Orator, Dr. Damitha Gunawardane, the President of KSM, Professor Samanna Nayakara, the Chairman of Scientific Sessions, Professor Tushara Kudagammana, the Joint Secretaries, Dr. S. Krishnapradeep and Dr. Nishan Dharmasena, and finally, the Treasurer, Dr. Tusitha Padeniya.
Thank you, sir. Now, I cordially invite Dr. Nishan Dharmasena, Joint Secretary of Kandy Society of Medicine, to deliver the welcome address.
Good morning, ladies and gentlemen. Bibile Memorial Orator, Dr. Damitha Gunawardane, Senior Lecturer in Community Medicine, Faculty of Medicine, University of Peradeniya, and his family and friends who are gathered here today. Family members of late Professor Senaka Bibile, Vice Chancellor Professor M.D. Lamawansa, Deputy Vice Chancellor Professor Terence Madhujit, Dean Faculty of Medicine, Professor Vasanthi Pinto, Dean Faculty of Dental Sciences, Professor Manjula Atigala, Provincial Director of Health Services, Dr. Nihal Veerasurya, RDHS Kandy, Directors of National Hospital Kandy, Teaching Hospital Peradeniya, Sirmao Bandaranagar Children's Hospital, and all Deputy Directors, consultants, professors, senior lecturers, medical officers, lecturers of National Hospital Kandy, Teaching Hospital Peradeniya, Sirmao Bandaranagar Children's Hospital, Faculty of Medicine and Faculty of Dental Sciences, organizers, speakers, resource personnel and of plenaries and symposia, presenters of oral and post presentations, president, past presidents, and members of the Council of the KSM. It is with great pleasure that I welcome all of you to the Professor Senaka Bibile Memorial Oration of the 46th Annual Academic Sessions 2024 of the Kandy Society of Medicine. which is also coinciding with the Diamond Jubilee of the KSM. This fine morning, we will kick off the 46th annual academic sessions with the traditional Bibile memorial oration by Dr.Damitha Gunawardane, and we have the pleasure of having members of the late Professor Senaka Bibile's family to witness the event. Steering through crisis and enhancing healthcare. This is our theme, and true to its meaning, during the past 1 year, we have steered the KSM and its associated academia through the troubled waters of the Sri Lankan economic and social crisis. And I feel that we have managed to do the justice to our theme and hence enhance healthcare in Sri Lanka. So welcome to all of you again. And without further ado, let me hand over the podium to the young energetic compeers to steer us through the rest of the sessions. Thank you.
Thank you, sir. The Bibile Memorial Oration 2024. Our orator is Dr. Damitha Gunawardane. To introduce him formally, let me invite Professor Samanna Nayakkara, the president of KSM.
Dr. Damitha Gunawardane, the orator today, Chairman of Scientific Committee, Professor Kudagamana, Joint Secretaries and the Treasurer of Kandy Society of Medicine, Dean Faculty of Medicine, Dean Faculty of Dental Sciences, Deputy Regional Director of Health Services, Central Province, Deputy Director, National Hospital Kandy, Deputy Director, Teaching Hospital Peradeniya, consultants from National Hospital Kandy and Peradeniya hospitals, professors, senior lecturers, heads of departments, lecturers and other doctors, members of the family of late Professor Senaka Bibile, and members of the family of and well-wishers of Dr. Damitha Gunawardane, ladies and gentlemen. So let me introduce the orator this morning, who is Dr. Damitha Asanga Gunawardane. Dr. Damitha Asanga Gunawardane is a board-certified specialist in community medicine and a senior lecturer in community medicine, Faculty of Medicine, University of Peradeniya. He received his primary and secondary education from Dharmaraja College, Kandy, where he had an illustrious career as a student. Dr. Gunawardane graduated from the Faculty of Medicine, University of Peradeniya in 2007. Immediately following his internship, Dr. Gunawardane started his public health journey as an additional Medical Officer of Health, or MOH, in MOH Kantale in 2009. He started his postgraduate studies in public health in 2011 and obtained the Masters in Community Medicine from the University of Colombo in 2012. Dr. Gunawardane obtained MD in Community Medicine degree from the Postgraduate Institute of Medicine, Colombo in 2015. Following his local senior registrar appointment in Family Health Bureau, he was attached to the Health Economics and Policy Unit of the School of Public Health, University of Adelaide, Australia, as a postdoctoral research fellow in 2017. He has been a board-certified specialist in community medicine since 2017 and is also a fellow of the Royal Society for Public Health, United Kingdom. During his public health career, he has served as a medical officer of maternal and child health in Kegol and Kandy districts, and as a consultant community physician in RDHS Kandy, Kegol, Nuwara and PDHS Central Province. Following 12 years of service in the Ministry of Health, he joined the Department of Community Medicine, Faculty of Medicine, University of Peradeniya as a senior lecturer in 2021 to pursue an academic career because of his passion for teaching. Dr. Gunawardane is currently involved in teaching and training in the postgraduate community medicine program at PGIM Colombo, and he is a member of the Board of Study in multidisciplinary study courses of the PGIM Colombo. Dr. Gunawardane has published numerous research papers in national and international journals. His main research interests are health economics, disease burden, and maternal and child health. He is a member of the editorial board of the Journal of the College of Community Physicians of Sri Lanka, and also serves as a reviewer for several national and international journals, including the Bulletin of the World Health Organization. Dr. Damitha Asanga Gunawardane has been selected by the Intra-Academy Medical Panel and the World Academy of Sciences as one of the 20 outstanding young physician leaders in the world to participate in the Young Physician Leaders Forum in conjunction with the World Health Summit in 2018, Berlin, Germany. Since then, he has been invited as a resource person for joint workshops organized by the Inter-Academic Partners and UK Academy of Medical Sciences, including the workshop on universal health coverage in low and middle income countries held in 2019 in London. Further, Dr. Gunawardane has contributed to developing national level standards, guidelines and policies, including cost analysis reports on every newborn action plan and strategic plan for adolescent and young health in Sri Lanka. He recently performed a consultant contract with the WHO to revise the supervision framework for the reproductive, maternal, newborn, adolescent and child health program in Sri Lanka. Ladies and gentlemen, I invite Dr. Damitha Gunawardane to accept the medal for the Bibile Memorial Oration and deliver the prestigious
So while we invite Dr. Damitha Gunawardane to deliver the memorial oration, I'd like to invite the rest of the members of the head panel to take their respective seats in the audience.
Thank you very much, sir, for the kind introduction. Very good morning to all of you. The President, past Presidents, members of the Council of the Kandy Society of Medicine, family members of the late Professor Seneka Bibile, dear teachers, colleagues, ladies and gentlemen. Professor Professor Seneka Bibile was a distinguished Sri Lankan pharmacologist and visionary who made a significant contribution to the field of pharmaceuticals and healthcare. Professor Seneka Bibile was born in 13 February 1920. His father was Charles William Bibile, a Rate Mahatya, well known for his dedication to fulfill the needs of poor people in Uwawelassa. Professor Seneka, as a schoolboy, excellent in arts, music, drama, dancing and sport. he entered medical school, winning the Fraser Memorial Scholarship. He achieved first class honors at second MBBS and in the final MBBS examination, obtaining distinctions in medicine and surgery and winning the Rockwood and Dada Boy gold medals. His work as the Regional Director of Health Services at Bingiriya demonstrated his altruism by providing free after-hours service in his quarters with free medicine and food. He joined the University of Colombo in 1947 and completed a PhD at the University of Edinburgh. He was the first professor of pharmacology in Sri Lanka and a founding member of the Faculty of Medicine, University of Peradeniya. He became the first dean of the faculty. He was instrumental in establishing the medical education unit at the Faculty of Medicine and the Kandy Society of Medicine in organization that harness collaboration. One of the Bibile's most notable achievements was developing the concept of rational use of drugs. This revolutionary idea emphasized making essential medicines accessible and affordable to all, especially in developing nations. He believed that a pragmatic and cost-effective approach to healthcare could significantly improve the well-being of the community. Bibile's philosophy prioritized the production of generic drugs over expensive brand medications, advocating for a fair pharmaceutical system that serves the people's interest. Despite his groundbreaking contributions, Professor Bibile faced opposition from powerful pharmaceutical companies that resisted his vision of affordable generic drugs. However, he remains steady in his principles, dedicated to create a more equitable healthcare system. Tragically, Professor Seneka Bibile's life was cut short when he passed away in 1977 at the age of 57. Nevertheless, his legacy inspires those committed to global health equity and accessible health care. The rational use of drug concept and the state pharmaceutical corporation remains integral parts of Sri Lanka's health system, serving as a testament of Bibile's enduring impact. Finally, Professor Seneka Bibile was a pioneer pharmacologist whose life and the work were dedicated to reshaping the pharmaceutical landscape in favor of affordability, accessibility, and equity. His legacy lives on through the enduring impacts of his ideas and the institutions he helped establish, leaving an intangible mark on the pursuit of the global health for all. In today's concept, newborn health in Sri Lanka is a good example for understanding Professor Seneka Bibile's vision to develop a more equitable, affordable, and accessible healthcare system. President and distinguished invitees, today I will talk about newborn health in Sri Lanka. The topic I have selected is Sri Lankan newborns, improving survival and well-being. Every day, 6,500 babies die in the first month of life. Every year, an estimated 2.6 billion newborns die worldwide. If current trends continues, 48 million children under age of 5 years are projected to die between 2020 and 2030. Half of them would be newborns. Therefore, further reduction in child mortality will only be possible through improving newborn health. Trends in neonatal mortality and disease burden. Over time, Sri Lanka has effectively implemented measures to decrease the neonatal mortality rate. Infant mortality in Sri Lanka has decreased from 17.9% in 1992 to 8.5% in 2015, while neonatal mortality has decreased from 13% in 1992 to 6% in 2015. Nevertheless, neonatal fertilities constitute over 80% of all infant deaths. Consequently, additional reduction in infant mortality are only achievable via enhancement in the newborn health. Neonatal mortality in Sri Lanka is primarily attributed to congenital anomalies, meconium aspiration syndrome, premature births, and neonatal sepsis. According to the trend analysis and the forecasting done by Gunawardane and others, based on the neonatal mortality data from 1990 to 2012, Sri Lanka is expected to have a neonatal mortality rate of 3.79 per 1,000 live births by 2025. From 2000 to 2012, Sri Lanka achieved a negative annual percent change of 3.6. Neonatal disorders are considered the leading cause of disability-adjusted life years in the whole age groups globally. When considering the under 5 age group, in 2019, neonatal disorders account for 36% of group's global deaths, increasing from 24% in 1990. Even in Sri Lanka, we could not see much improvement in the percentage contribution by the neonatal disorders for the under 5 age group global deaths. This is purely due to the slower progression in neonatal health concerns compared to the other causes of mortality and morbidity that contribute to under 5 mortality. During the same period, Sri Lanka has reduced the disease burden due to neonatal disorders among the under 5 age group by 70%. But still, newborn causes account for 40% of the under 5 disease burden in Sri Lanka. Therefore, reducing neonatal mortality and morbidity will be key to reducing under 5 mortality and morbidity in Sri Lanka. Outcomes of Sri Lankan newborns. Based on the available literature, the prevalence of preterm birth in Sri Lanka varies from 5 to 10%. A study by Tanha and others covering 21 countries, including Sri Lanka, described outcomes of preterm newborns. According to study findings, 33.8% of preterm neonates were delivered through cesarean sections. The prevalence of low birth weight was 61.5%, while 43.3% had birth weight less than 1,500 grams. Nearly 10% of preterm newborns had an ABGA score less than 7 at 5 minutes, and 4% had neonatal intensive care unit admissions. Gunawardane and others evaluated the neonatal outcomes of term neonates at a teaching hospital in Sri Lanka. Before the initial hospital discharge, the neonatal outcomes of full-term neonates were described in descriptive follow-up study. The mean gestational age at delivery was 38.85 weeks, and the most term neonates were delivered at 40 weeks. Out of all, 41% were delivered before the completion of 39 weeks. Pereira and others also reported similar findings in their study, where 42% of term neonates were delivered before the completion of 39 weeks. In the present study, the average birth weight of the term neonate was 2,925 grams. Among the participants, 13.7% had birth weight below 2,500 grams, and 10.9% had birth weight of 3,500 grams or higher. The mean birth weight was consistent with the Pereira and other studies, where the neonates' mean birth weight was 2,930 grams. Maternal prepregnancy weight, maternal height, and gestational weight gain all showed a significant positive connection with the neonatal birth weight in the analysis conducted by Gunawardane and others. The strength of association between maternal anthropometry and the birth weight was higher in baby girls compared to baby boys. Maternal pregnancy weight, maternal height, gestational weight gain were found to have significant relationship with the neonatal birth weight in multiple linear regression. The duration of hospital stay was measured in inpatient days. In accordance with the national policy, term neonates who are delivered vaginally and have a normal birth weight are to be discharged from the hospital 24 hours after birth. Nearly 70% of the neonates delivered via normal delivery were discharged within 2 days, primarily attributed to the higher cesarean section rate among the study group. The median length of hospital stay was 3 days. At least one neonatal condition was diagnosed in 23% of 1,105 neonates included in the study. Admission to the neonatal care unit was necessary for 15.8% of the term neonates. The median age at the admission was 1 day, and the most neonates admitted to the neonatal care unit on first day of their life. Bacterial sepsis of newborn was the most prevalent neonatal condition, followed by respiratory distress of newborns and jaundice from unspecified and other causes. It is necessary to address the high incidence of bacterial sepsis by enhancing aseptic procedures from birth until the patient is discharged from the hospital. Cost of newborn care in Sri Lanka. Although cost evaluations of newborn care are increasingly available from other countries, costing data in Sri Lanka neonatal care services are largely unavailable. Regarding preterm newborns, Nelundeni and others conducted a study determining the cost of management of extremely low birth weight infants in tertiary care unit in Sri Lanka. The study includes 39 extremely low birth weight babies. Birth weight ranges from 540 grams to 980 grams. As estimated in the study, direct cost per survivor was 82,207 rupees in year 2010. Due to the unavailability of costing data related to neonatal care services in Sri Lanka, Gunawardane and others conducted a cost analysis to explore the neonatal care cost of term neonates with adverse neonatal outcome. Adverse neonatal outcome was defined as a composite measure of neonatal death, morbidity, which need admission to neonatal care unit before the initial discharge point. The study observed 175 term neonates who had experienced adverse neonatal outcomes. The main perspective taken was that Ministry of Health, Sri Lanka. Despite the potential benefits of conducting an analytical costing study, the study was confined to cost analysis due to the limitation of available hospital-level data. Moreover, there is a lack of disease costing studies focusing on neonatal care in Sri Lanka, so this would be the first one of that kind. Total neonatal care cost during the study period, including the government and out-of-pocket cost, was 12.1 million rupees. Of 92.9% consisted of government neonatal care cost. The largest contribution to the government neonatal care cost of term neonates with adverse neonatal outcomes was by the shared direct cost, including staff salaries and allowances, cost of surgical consumables, and cost of shared equipments. Staff salaries and allowances comprises 90% of the shared direct cost. The present study found that the drugs were more expensive than laboratory tests. With the relative high prevalence of neonatal sepsis, the main contributor to that was antibiotic treatment. The median total neonatal care cost per term neonate was 50,000 rupees with an interquartile range of 39,000 to 79,000 rupees. Infants admitted to neonatal care unit on the first day of life incurred highest average cost for neonatal care compared to those admitted later. Additionally, being delivered at 37 weeks, being male and having birth weight below 2,500 grams were factors linked to increased mean total neonatal care cost per term neonate experiencing adverse neonatal outcome. Among term neonates experiencing adverse neonatal outcome, the top 4 prevalent conditions were bacterial sepsis of newborn, respiratory distress of newborn, neonatal jaundice from other and unspecified causes, and birth asphyxia. They accounted for nearly 70% of overall expenditure. Notably, respiratory distress syndrome emerged as the main contributor, representing 25% of the total cost for neonatal care. This highlighting cost in term neonates with respiratory distress syndrome was attributed to both the higher number of cases and the expensive support they required. However, when considering the neonatal care cost per term neonate, birth asphyxia was the most costly neonatal condition to manage. Newborn care in the field. A follow-up study of 1,105 term neonates included in the study by Gunawardane and others captured the neonatal outcomes following initial hospital discharge. A telephone interview was scheduled for term neonates whose mothers had been given consent to participate in the interview. The interview were conducted between 39th to 35th day following delivery for neonates already discharged from the hospital. Out of the initial recruited 770 mothers before hospital discharge, only 57% could be reached. Consequently, 421 mothers took part in and completed the telephone interview. Since the field services would not be changed based on the gestational age, this study provides snapshot of the postnatal service delivery in the field for all newborns. After being discharged from the hospital, almost half of the mothers sought medical advice for their newborns. Among those seeking advice, 71% consulted general practitioners and 28% reached out specialists. Notably, all mothers acknowledging neonatal health issues sought advice from healthcare professionals. This practice significantly contributes to the sustaining a relative low neonatal mortality rate in Sri Lanka. Exclusive breastfeeding is given no other food or drink, not even water, except breast milk. It does, however, allows infant to receive oral rehydration salt, drops, and syrup. Most women exclusively breastfed their babies. Out of 6 formula-fed babies, 1 had a hospital admission, while 4 out of other 5 babies had sought medical advice from either a specialist or an ordinary doctor. The exclusive breastfeeding rates was higher than the Demographic Health Survey 2016 and 17 report, where the exclusive breastfeeding rates were 93.4% and 1.8% of formula feeding at 1 month of age. This difference could be due to the difference in the gestational age at birth, since premature neonates are generally at a higher risk of initiating formula feeding. Notably, among the 6 neonates, the 5 who had been on formula milk had received medical advice from a qualified practitioner. Therefore, it is crucial to emphasize to all healthcare professionals the significance of promoting exclusive breastfeeding over resorting to formula feeding. There were no deaths among studied neonates following initial hospital discharge until their neonatal period is over. 19 neonates were hospitalized during the neonatal period, and the most common reason for admission was breathing difficulty followed by yellow coloration of body. According to the policy, the initial postnatal visit by the public health midwife should occur within 1 to 5 days of delivery. In this study, only 37.7% of the participants received the first visit within the specified time frame, and 78.4% had the first home visit by the PHM within initial 10 days after delivery. A mere 3% of neonates had not undergone any postnatal visit by PHM by the time the telephone interview was conducted between 29 to 35 days of postpartum. The survey revealed that the majority of neonates had a scheduled appointment for the postnatal clinic visit by the time of the assessment. 6 key aspects of postnatal care at home supported by the PHMs were assessed based on the mother's response at the telephone interview. A considerable proportion of mothers stated that the postnatal visits were not helpful in any of the 6 aspects questioned in the telephone interview. Postpartum visits had the highest impact on breastfeeding, followed by maternal competence in recognizing danger signs. But the postpartum visit had the least impact on keeping the baby warm and dressing up of the baby. Lactation management centers to support breastfeeding. As highlighted in Gunawardane and others, quite a few mothers and babies face difficulties in the breastfeeding, requires professional help. In addition to home-based breastfeeding support by public health midwife, in order to provide quick outpatient support to breastfeeding mothers, the Lactation Management Center was introduced to the Sri Lankan specialist hospitals in year 2000. To explore the activities carried out in lactation management centers, Gunawardane and others conduct an audit among lactation management centers established in Western Province, based on the LMC monthly returns received by the Family Health Bureau in year 2015. Even though 12 established LMCs in the Western Province, only 11 centers had sent at least one return to Family Health Bureau during that year. In total, 24,353 mothers received care during this period. The median number of visits per month per center was 135, ranging from 2 to 941. Average number of visits per month per center was 219. Except for one unit, all the other units had standard number of officers attached to LMC and were kept open for the standard opening hours. The common reasons for LMC referrals were difficult attachment, incorrect burping technique, and poor weight gain. Nearly 90% of the referrals were diagnosed to have incorrect positioning and attachment. Only 7.7% of mothers were diagnosed to have any breast condition. The commonest neonatal condition diagnosed was cleft lip or cleft palate. Nearly 17% of neonates were low birth weight and 1% of newborns were formula fed at the time of the referral. Every newborn action plan in Sri Lanka. Nearly half of all under 5 deaths in 2020 occurred during neonatal period. This increase from 1990 as a global level of under 5 mortality declines faster than neonatal mortality. 5 million children died before the 5th birthday, and half of those deaths occur among newborns. Mortality can be assumed to be just a tip of iceberg in the disease that kill but often will road to survivors into long-term effects. Underestimating and neglecting neonatal diseases carries this burden into adulthood, resulting in economic and social cost. After recognizing the importance of this issue, World Health Organization and United Nations International Children's Emergency Fund proposed every newborn target for the post-MDG era. To meet every newborn target of 10 or fewer neonatal deaths and 10 or fewer stillbirths per 1,000 births in every country by 2035. Sri Lankan Every Newborn Action Plan to end preventable morbidity and mortality was developed with a vision to ensure that Sri Lanka is a country in which there were no preventable deaths and illness of newborn and stillbirths, where every pregnancy is wanted, every birth celebrated, and women, babies, and children survive, thrive, and reach their full potential. The following 2 goals were identified to achieve the national vision on newborn health. Goal 1, to reduce neonatal mortality rate from 6.5 per 1,000 live births in 2013 to 4.2 thousand live births by end of 2020. The goal 2, reduce the stillbirth rate from 6.4 per 1,000 births to 4.5 per 1,000 births by end of 2020. In SLENAP, strategic objectives and key activity areas were identified and described under 4 priority packages: care during labor and childbirth, essential newborn care, care of sick and small newborns, and care beyond newborn survival. Gunawardane and others performed a cost analysis of SLENAP. It was developed with the input of experts in the relevant fields. The analysis provides a guidance for the implementation of newborn healthcare activities at national level and district level. It also provides a basis for advocating funds to meet specific goals. There were two parts in the cost analysis. Gunawardane and others focused on the cost of 9 specific intervention packages included in every newborn action plan in the first part. The second part focused on the cost of priority activities selected from SLENAP. The costing of interventions was confined to the focus interventions used in the bottleneck analysis of every newborn action plan. In addition to key every newborn action plan interventions, intervention cost for newborn screening for congenital hypothyroidism was also included in the analysis, since it is a very important newborn intervention in Sri Lanka. Interventions are costed using bottom-up approach. The model calculates the total cost per year and cost per case. In this costing exercise, the intervention costing was limited to the inputs such as drugs, supplies, staff time required, and number of visits or hospital days. Estimates of the staff time linked to the interventions and the number of visits or hospital days were based on the WHO's One Health model intervention treatment assumptions and the available Sri Lankan norms and the standards. The expert opinion was also obtained to specify the type and the amount of drugs, supplies, personal time required for each intervention, and then cost these inputs using unit items, item cost in rupees. The unit price of the items were mainly extracted from the sources from the Ministry of Health Sri Lanka. The population needing the specific interventions was identified using publications of Ministry of Health Sri Lanka and other available literature. The cost of capital equipments used in specific interventions was calculated assuming 5-year working life and norm given by the Ministry of Health Sri Lanka. When considering the average cost per intervention, care for newborn sepsis had the highest average cost per intervention, followed by cesarean section. However, cesarean sections were identified as the costliest every newborn intervention when considered the annual total cost per intervention. In the calculation, the cesarean section prevalence was considered 33.8%. Nevertheless, according to the prevalence of cesarean section in the year 2021, this cost would be much higher. According to the forecast performed by Gunawardane and others, through ARIMA technique, the cesarean section rate will be increased to 50% by 2025, costing $12 million USD per year. When consider the impact on the total every newborn action plan intervention cost, cesarean section contributed 32%, followed by 23% due to the care of newborn and sepsis. Priority activities selected for SLENAP were costed in the second part of the analysis. This part of costing mainly focused on providing standard equipment sets to the facilities from 2017 to 2020, in addition to the capacity building activities. The data sources used to obtain the unit prices are similar to the intervention costing. These selected activities fall under 3 major areas of SLENAP: care during labor and childbirth, essential newborn care, and care of sick and small newborns. Nearly 3/4 of the total estimated cost was allocated to the activities to promote and support care of sick and small newborns. This is mainly due to the strategic directions to develop fully equipped neonatal care unit network with 4 levels of facilities. According to the estimated cost of establishing standard neonatal care units, the newborn care related setting cost to be established neonatal care unit range from $327,000 to $630,000 USD. standard 8-bed labor room will cost around 55,000 USDs. The total cost for SLEENAP 2017 and 20 priority activities was 7.8 billion rupees. Based on the estimated cost, 74% of would be required for the care of sick and small newborns. This finding emphasized the importance of preventing preterm births and adverse outcomes among newborns. The total healthcare expenditure in 2017 was 479 billion rupees, around 3.6% of GDP. Based on the total health expenditure in 2017, the total expenditure for SLEENAP 2017 and 20 priority activities would only account for 1.6% of the total health expenditure. However, the ministry had spent 90% of the expenditure on recurrent cost, which hinders the implementation of strategic plans like SLEENAP. According to the provisional data in 2019, Sri Lanka had a neonatal mortality rate of 5.03 per 1,000 live births, which is bit off from the expected neonatal mortality rate to reach 4.2 by 2025. This may be due to the incomplete implementation of SLEENAP during the stipulated time frame. This is high time to evaluate SLEENAP 2017-20 implementation levels and to identify the bottlenecks and progress towards the 2030 SDG targets. How many lives are at stake? According to the analysis by Lone and other neonatal mortality, to achieve the global SDG target of 10 or fewer neonatal deaths per 1,000 live births by 2035 globally, Sri Lanka needs to achieve a neonatal mortality rate of 2 per 1,000 live births by 2035. As per the national strategic directions, to achieve the SDG target by 2035, Sri Lanka needs to achieve the neonatal mortality rate of 2.2 per 1,000 live births by 2030. To achieve that, from the latest available neonatal mortality rate of 6 per 1,000 live births in 2015 by Registrar's General Department, Sri Lanka needs to maintain a negative annual percent change of 6.5% from 2015 to 2030. That means if Sri Lanka can achieve this target by 2030, it will save nearly 7,000 newborns. There are quite direct implications of the evidence generated to promote health of neonates in Sri Lanka. Prevention and control of infection at the time of birth in the labor room and the operation theatre, in the postnatal wards and in the neonatal care unit should be given due attention to reduce bacterial sepsis among neonates. The effective coverage of postnatal domiciliary care needs to be improved. Methods to ensure timely postnatal visits by the public health midwife need to be evolved. The skills and the competencies of public health midwives in the provision of domiciliary care for neonates should be improved. Specifically, to guide the mother in the essential care of newborn should be improved using techniques such as observation checklist. More research is also needed to understand the most appropriate approaches in the field neonatal care to maximize the impact of postnatal visits by the public health midwives. The use of clinical audit checklist for labor management, labor induction, cesarean sections, and prevention and control of infections at birth in the postnatal wards and the neonatal care units will improve neonatal health. In clinical auditing system, and a review mechanism should be developed to routinely monitor the indications and the outcomes regarding induction of labor and the indications for cesarean sections and the rate of infection in the postnatal wards and the neonatal units. Considering the cost implications of adverse outcomes among neonates, all possible measures must be taken to prevent them, especially as a country thriving through an economic crisis. Finally, it is the high time to evaluate the SLENAP 2017-20 implementation level to identify bottlenecks and to progress towards 2030 SDG targets. At this juncture, I sincerely thank my beloved supervisor, Dr. Damitha Asanga, Consultant Community Physician, Health and Nutrition Officer, UNICEF, Sri Lanka, and the former Program Manager of Newborn Health at Family Health Bureau for her continuous guidance and support. Dear Madam, without your guidance, I will not be able to deliver this oration on newborn health today. Professor Samath Dharmaratne, my postgraduate supervisor, thank you, sir, for your guidance and support. The Director Family Health Bureau and all the program managers in the past and the present for their support. President, Secretary, and the Council members of the Candice Medical Society and the family of Professor Senaka Bibile, thank you very much for this opportunity to share this evidence on newborn health in Sri Lanka. Dean, Faculty of Medicine, Peradeniya, thank you, Madam, for your guidance and the support during past 3 years. And all my department member colleagues are remembered at this moment, thankfully, for their kind support. And distinguished invitees, ladies and gentlemen, thank you for your presence and the patience in listening. And last but not least, I thank my parents, my sister, my wife, and my daughter for being my strength in every step of the way. Thank you very much.